Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins, family medicine physician and senior physician advisor here at the AMA. When patients seek care, whether at a small practice or a large health system, they bring with them more than their ailing body, sometimes a lot more. As human beings, we are multidimensional. Our physical, emotional, spiritual, and social health, as well as the environment in which we live, are all interconnected. Providing optimal healthcare that is individualized and supports all facets of the complex human condition requires a wide lens, a breadth of expertise and experience. The whole person care delivery model aims to promote wellness by addressing all facets of a person's health. To explore what whole person care looks like in practice, I'm joined by Dr. Wayne Jonas. Dr. Jonas is a board-certified practicing family physician, an expert in integrative health and whole person care delivery, and a widely published scientific investigator. Dr. Jonas is a retired lieutenant colonel in the Medical Corps of the United States Army. He is the founder and president of Healing Works Foundation, a not-for-profit organization where the mission is to make whole person integrative care regular and routine. Thank you, Dr. Jonas, for your service to our country and for being our guest on the podcast today.
It's my pleasure to be here. Thank you for inviting me, Dr. Hopkins, and please call me Wayne. If that's okay, I'll call you Kevin.
That sounds great. Thanks, Wayne. Glad to have you. Before we dive into our discussion about whole person care, would you mind, Wayne, by telling our listeners a little bit more about yourself and your background?
Happy to. I think I got interested in more than the body and bringing that into healthcare, actually from my father, who was a chaplain, a hospital chaplain. During my formative years, he would go into the hospital and I'd ask him what he's doing. And he says, well, I'm helping people heal. And I thought that's what doctors did. What do you do? And so I learned that there were deeper aspects to healing than what I was going to learn in medical school eventually. Still wanted to be a doctor, but got very interested in that. I'm surrounded by chaplains, it seems. My daughter is also a chaplain, also did training in hospital chaplaincy. And actually, before I went to medical school, I did a 6-month internship as a student hospital chaplain. I knew I wasn't going to be a minister or a chaplain, but I said I wanted to know what it's like. So I actually went to Union Theological Seminary and did 6 months CPE, Clinical Pastoral Education Program, and then I went to medical school. So I always had that sort of interest in sort of what's at the center of this mind and spiritual component of a human being, and why is that, and how is that important to bring in? Then I spent the first 20 years of my practice as a family physician in the military. And as people may or may not know, military is more than just treating disease. They got to keep their folks healthy, right? You got to be able to drop, anything at the drop of a hat and go out and defend the country. So it was very holistic. It was very preventative. It was very health promotion and performance optimizing. And there were resources invested into that. And I was first stunned and then distressed when I got out of the military, went into the outside and saw what a fragmented, partial, and sort of late stage system that we had for treating disease that really didn't focus on health promotion that much, a little bit of prevention, but really waited for people to get sick and then threw very costly resources at them. And I think this framing is really at the root of many of the healthcare problems we see in our country now. Rising costs, the increasing mortality and the poorer health that our country is going in, and the increased burnout on the treadmill as we mop up things instead of going upstream and get at the underlying determinants of health. And so I sort of dedicated my time to saying, hey, can we make a more whole person health system in the regular world, in routine practice, that actually helps both stop or in many cases reverse some of the chronic diseases we see day to day in medicine.
What a fascinating and unique background you have, Wayne. So growing up, my dad was a pastor and served as a hospital chaplain. And I recall having very similar conversations with him as you did. And so very interesting to hear about your background. I'd like to ensure also some understanding of some essential vocabulary as we get into this discussion. So, you hear things, terms and sort of categories in medicine, like whole person care or integrative medicine or lifestyle medicine. Are these and others, are they all synonyms to be used interchangeably, or are they distinctly different? And if so, how are they different from what we think of as traditional primary care?
Yeah, that's a great question. And it is very confusing because these terms are thrown about. Often, if you look at some of the definitions, they look identical. But when you get into the actual practice, they can be quite different. And so it's important to kind of understand the difference. I actually wrote an article about this in the Journal of Family Practice, published in 2020, that really sort of gives the entire lay of the land and shows where these terms fit into what I call advanced, or what's called advanced or high quality primary care. But let me just give you just a couple things that distinguish these different terms in my mind and how they should be used. I use the term whole person care really to talk about paying attention to the goals of the individual, what matters to them, what are their long-term goals, and helping have that conversation, and then paying attention to at least four dimensions of their life, their physical environment, their behavior, their social and emotional component, and the mental and the spiritual, what's really important to them in life. And then focusing on health promotion, health creation, or the term I like is salutogenesis, because it compares so nicely to pathogenesis, which is what we learned in medical school. So that's whole person care, and we'll talk about a little bit more of that as the podcast goes on. There is the term integrative care, and that is used mostly to talk about integrating so-called alternative or complementary practices, things that have been outside of the mainstream, but now we're beginning to get evidence. For example, acupuncture for pain, stress management, meditation, mindfulness for depression, anxiety, for example, where the evidence is now emerging that these modalities added to a practice can really help. It can build your toolbox, and integrative care is putting those things together. Many of those practitioners have added behavior and lifestyle, nutrition and things like that, and so you do see elements of lifestyle in that, but it's not the primary focus. Lifestyle medicine, which is another term, and there's been a growing movement to develop lifestyle, focuses mostly on sort of the core health and wellness factors that we know contribute to many chronic diseases. So these are things like diet, activity, sleep, and stress management. Those are the core factors. And that group then will also then add on sometimes the social and emotional components, the mental and the spiritual components to that, but the main focus is largely those lifestyle. And so that's what distinguishes, I think, these different kinds of practices and terms. They're all trying to get, in my opinion, at whole person practice. And so that's the framework that we use in our foundation and in our work.
Okay, very helpful. So what's the end goal or the purpose of whole person care? Are there main goals and secondary goals, or what's the underlying premise and purpose behind whole person care?
I think the underlying fundamental goal is to tap into our inherent healing capacity and help the person drive those factors, pay attention to them. We treat disease and then we say, go home and recover. Okay. So the healing part sort of is a side effect. We expect it to happen. It does happen. All right. But we can actually enhance that. We can actually facilitate that. And when it comes to chronic illness, if we paid more attention to those things earlier on, we can even prevent a lot of the diseases that come in those areas. So that's fundamentally the goal. Now, that can't occur unless the patient is an integral part of their own health, right? They have to generate their own health because a lot of it is based on their particular environment, the behavior they engage in, and that type of thing. So they have to become a partner in this process. It can't be something we just do to them. and prescribe to them. So this requires that we build a relationship, a trusted relationship with them, and we hear what their goals and help them suss out what their goals are, and then provide them with support resources to move in that direction. And I think that's fundamentally the difference between sort of the disease treatment and the health promotion or the health creation whole person component. We have a lot of tools in medicine for treating the latter, for doing the latter, the SOAP note, the subjective, objective assessment and plan. That's how we document everything. It's based around coming up with a diagnosis and a CPT code and this type of thing, and then linking it up to a particular treatment. And we've proposed that we come up with a similar framework and set of questions. We call it the HOPE note, the healing-oriented practices and environments component, which really look at the health drivers, starting with the goals, the long-term goals of the person, and then looking at where they are in those health drivers, including lifestyle, the social and emotional part, and their own existential and meaning component of that. So bringing the person through a relationship into the actual practice.
Great. So the organization for which you are founder and president, the Healing Works Foundation, describes whole person care as person-centered, relationship-based care. Could you walk us through some of the key aspects of whole person care from a practical standpoint?
Yeah, so I'll go back to some of the tools in this toolkit that we call the Hope Note Toolkit. They actually have been tested. We ran a learning collaborative around the country of, I think, 13 different centers around the country, primary care centers mostly, and actually tested these tools out, refined them in those areas, and we have them available on our website, and they're available other places too. Published a couple articles in the Annals of Family Medicine and the Journal of the American Board on that. And it basically comes down to some very practical tools that you can access. One of them, a simple 2-page patient questionnaire that I give to folks to allow this conversation to be had, is called the Personal Health Inventory, the PHI. Now, we derived this from the VA. The VA was using this in their whole health program, and we said, hey, it allows you to have a rapid and easy reframing and conversation around health promotion with patients, gets at their goals, and it identifies their needs. That patient identifies what are the core needs they have in wellness and health promotion, whether it's sleep or diet or activity or whatever it happens to be. So we recommend people use that, okay? They take the PHI and they actually have a visit where a patient can fill it out ahead of time. For some of my patients, they come in, they fill it out right before they see me, and we use that to have the conversation. And that's the Hope Note that documents that conversation, that fleshes those things out and identifies, all right, what are the key wellness and health promotion factors that are needed at this time that can help their chronic disease, that aligns with what they say they need, what matters to them. And that then provides a personal health plan. Having resources available, many of which are already around and in practices. So it's just a matter of organizing them to deliver them more efficiently, or they're in the community in some cases, so getting linked up to those so that you can make them available. And then adding those tools, I think, is the most practical way. We found in the Learning Collaborative that over 85% of those practices found these tools easy to use. They brought them into different prices. Some of them, in fact, right there at the Cleveland Clinic where you work, family medicine brought it into the annual health wellness visit and trained all of their family medicine residents there on how to do that. Others have focused on high risk and high cost patients, the ones that are really having challenges, and then have isolated those and said, let's have these kinds of visits there to really flesh out what you need and how we can support you in a more integral way. So those are the practical steps for actually doing this.
So rather than us as physicians or the care team, sort of making some presumptions and assumptions and telling our patients, well, here's what you need, is that part of the strength of that PHI, that personal health inventory, that it allows the patient to tell us what they need in order to best support them in their health journey?
That's exactly right. One of the first questions they're asked is, what's important for you in your life? What brings you joy? What gets you up in the morning? Why do you even want to have health? And we ask people to write that in verbatim, okay? And that's where we start the dialogue. So immediately you get to know the person. So the relationship bonding beyond the medical part starts. And then they identify their own health and wellness needs. In the latter part of the questionnaire, they rate from 1 to 5 where their needs are. And so you can say, okay, well, let's talk about this one that you identified as sort of the most important thing. For example, sleep, or I want to lose weight, or whatever those particular goals are. And then begin the process of aligning it with their medical needs in the process, and that's what we put into the health plan.
So I've got to ask this question. I'm a primary care physician. I'm a family doc like you. And as I hear you talk about this way, and I think, well, yeah, this is what I was trained to do. This is what I do every day as a primary care physician. And yet I know that I don't do it to the extent or with the expertise that that we're talking about in this model. So, I mean, a patient of mine comes to mind who he wouldn't take care of his diabetes, his hypertension, his hyperlipidemia, chronic kidney disease, his CHF, all the other things, because he wouldn't do it for himself. But finally, we got to the conversation of what he was really afraid of was not living to walk his daughter down the aisle. How is this different from what maybe we as primary care physicians have been trained to do and have done traditionally?
Yeah, well, you hit it. You hit it right on the head here, Kevin. Exactly. You just described how you found out what was important for this person, right? And that is the center of whole person care, person-centered care, right there. Finding that out. It's not always obvious. Sometimes it requires we sit, we listen, we let it emerge out of the relationship, out of the conversation. There needs to be room for that conversation to happen and a trust. I remember a guy very, very similar to that. He had chronic back pain for a decade. He'd had a couple surgeries. He was on lots of drugs, et cetera. And finally I sat down and I said, well, what's the key issue here? And he couldn't actually drive to see his grandkids and sit down on the floor to play with his grandkids. And that's what he wanted to do. I marched him up to the physical therapy department and I talked to the physical therapist. I said, listen, this guy's willing to go through pain to get to the point where he can sit down on the ground. And he was. And so she did some things with him that, she hadn't been doing with him to actually strengthen his core muscles. And he got motivated to do that. And about 3 months later, he came in and he said, hey, I'm doing it. I'm getting down on the ground. I'm playing with my kids. Thank you very much. It wasn't easy, but it wasn't something just sending him up, without that kind of motivation. Letting that emerge is core. That's what we mean by when we say what matters, right? And then finding sort of the 1 or 2 things that they're willing to then work on to move them in that direction.
So certainly this seems very applicable, this type of care model, specifically to primary and preventative care, as we've spoken about. Is that the extent of its utility, or is it also applicable to specialty care of various types?
This applies broadly in healthcare. And I think it would do us all good if we got on board and at least began to make sure that we don't neglect certain things about a person, regardless of what we're doing, even if we're just mechanically going in and fixing stuff. And you can see examples of this really all over the country and all over the world. One of the best whole person care programs around that I've seen in pain management is actually run out of an orthopedic clinic down in Texas. And they have, people that come in all the time to get joint replacements. But if they then begin to develop a relationship, talk about, the behavior and the lifestyle, the mental health issues that are going on, help them to lose weight, improve their chronic diseases, and then do the joint replacement, they get much better outcomes, much better results from this. That's a whole person care in a surgical specialty. And then, of course, the area that we're doing at our foundation now specifically is in the area of oncology. We partnered with an oncologist, a great oncologist by the name of Alyssa McManaman, to really look at, how do you do whole person cancer care? So yes, this has application beyond primary care, I think, widely. Systems, I published another article in JAMA Health Forum a couple years ago, actually 2 years ago, that really talked about how do you design a system so that this can cut across all the different specialties that are delivered.
So you mentioned Dr. Alyssa McManaman. That you are an accomplished author. Your first book, How Healing Works, was published in January 2018, and I know laid out a new way to approach injury, illness, and wellness. And then just recently, your second book, Healing and Cancer, A Guide to Whole Person Cancer Care, which you co-authored with Dr. McManaman, was published just April 23rd of 2024. Why is whole person care particularly important in cancer care?
Well, we decided to go into cancer care and apply these same principles there for a couple reasons. One is that the primary care is starting to reimagine. It's always had these principles as a core part, but it's starting to reinsert these back into leadership and policy and payment structures. For example, if you look at the National Academy of Sciences and Medicine high quality primary care report that came out several years ago, it has embedded in its definition the concept of whole person care, and we're working closely with them. And now that's starting to get into policy and delivery, and there's a whole committee, and HHS is beginning to get involved in how do you pay for these types of things. So primary care is sort of the horse has left the barn. It's moving back into whole person care in those areas. We looked around and we said, where's the next area that really needs this the most? And we did a couple surveys actually, exploring sort of what patients wanted and what oncologists and care teams wanted. And we did that also for 2 years in a row in the cancer care. And we found out that patients really wanted to be treated as a whole person, not just to have their cancer hammered at. Patients wanted it. The science sort of demanded it. The oncologists started asking, how do I do this in those areas? So that's what motivated us to go to partner with Dr. McManaman and to go into the whole person cancer care and translate these principles into cancer care. We used a process very similar to what we did in primary care. We put together a leadership group from around the country, a learning collaborative. We translated many of these tools specifically into oncology care. Those are summarized in the book, and we created a CME program that's free and available for folks. And we're partnering with the American Cancer Society and putting together examples and case studies of how this is being done around the country and indeed even around the world. To deliver it through practice improvement, quality improvement practices.
Yeah, thanks, Wayne. That makes so much sense. I've had so many patients obviously go through cancer treatment and unfortunately some very close family members as well. And, we think about the medical aspect, but this is a whole person that we're taking care of. And oftentimes cancer care specifically tends to be something we do to patients rather than doing it with them. In the office yesterday, I had a patient come in, just gotten some lab results back, and I had to share with her some unfortunate news about a likely new diagnosis of leukemia. And, she wasn't interested about the immunologic phenotype of her lymphocytic cells. She was interested in, do I need chemo? Am I going to lose my hair? Do I need to cancel our trip to Disney for next month? All of those types of things were far more important, and that's what we spent our time talking about.
No, that's exactly right. What matters to the person there is really important, and we tend to ignore that because cancer generates fear immediately, right? The first thing you think of is death, and people get fear, and they kind of submit to anything. And our treatments are pretty harsh, and they interfere with a person's life. And so, even more important, why you ask, what can I do to help you live your life in the most normal way possible as you're going through this? And, that's the what matters question in cancer care. And that's exactly right. And adapting our treatment plans to make sure that that person has that quality of life as much as possible as they're going through that.
What do you think is most misunderstood about the concept of whole person care?
I think the thing that comes up over and over again that I hear from clinicians, clinical teams, is, I don't have time to do this. I am so busy. I've got so much that I've got to get done that is evidence-based, that is, part of the guidelines. How can I add this to the component? They see it as sort of, well, now I've got to boil the ocean. Okay, I've got to do everything. And I think the most misunderstood thing is this is not boiling the ocean. This is not the same thing as comprehensive care. This is not the same thing as having a longer checklist to go through. This is really about a way of being with the patient in which the drivers of the healthcare for them emerge and their engagement emerges, listening to them to see, where they're ready to go and how to incorporate that into the plan, and then designing the practice delivery system so that there are supportive aspects for that. So you can actually help make that happen with those resources. Yeah, every patient is unique, but you know what? There's a common set of factors that you see over and over and over again. And they may come together in a unique way with the patient, but they're still there. So if you have them organized, those common set of factors, then you can actually deliver them. And it isn't simply adding more on, it's actually delivering them in a more effective and a more efficient way, in a way that engages them and makes them a partner of that. I think that's the misunderstood part is it's another way of approaching patients that gets at the heart of what they need and the relationship component. It's not simply adding more tools on top of things.
Are you able to give any tips on maybe some very basic next steps that I could take, that one of our listeners, a physician in any specialty, could take from where I am, current day, current state, to move me towards more whole person care and taking a more whole person care approach in my day-to-day practice?
So there's several things that can be done. Number one, we have 3 free CME programs that are out there that were developed with the Center for Education at Tufts University. One of them is focused on pain and pain management. So if someone does a lot of that, how to do whole person care in pain management, especially those who are on narcotics and other kinds of painkillers. Another one is looking at primary care delivery of whole person care. That is a 15-hour free CME program. You can get AMA credit for it in those areas. And then one that's just out this month is on cancer care, whole person cancer care. So get some CME in those areas. I think bringing some tools into the practice and then meeting with your teams to embed the use of those tools in a routine way would be the second thing that I would recommend. And the PHI is where you start, the Personal Health Inventory. It's available to download on our website. We've also partnered with a tech company who has made, in a very inexpensive way, an automated way that you can do this. You just send a link to your patients, they fill it out. You can actually write the hope note in it, your plan, and you can integrate it into your electronic health record. It's called the Easy PHI. And then there's a variety of other resources. We have summarized a lot of the evidence for the kinds of healthcare practices, nutrition, education, complementary practices where there's evidence, et cetera, in pocket guides that are available. They can be printed out for patients. They can be used to educate your teams and your staff. And then I think the third thing that practices can do is that don't start with everything. Identify a particular population you want to try this with. So those kinds of practice improvement tools and processes, I think, are the ways to get going. And you can start from as simple as simply handing a patient a PHI or sending them the link to the Easy PHI, all the way to kind of redesigning the system so you're doing, this salutogenic part with selective patients.
Wonderful. Thank you. Are there any other points that you think are critical to share with our audience today as we sort of round out this discussion?
Yeah, I think one of the things that's important to understand, as you know, burnout and physician well-being, clinical well-being for that matter, has gotten worse and worse and worse. COVID really piled on top of that, but it was already getting worse. Part of that is really about not having the relationship with the patient because we're too busy doing the medical checklist. Not the job, but the work of medicine. Paying close attention to this is really important. The first thing to do is make sure you're taking care of yourself. If you're a clinician, if you're a physician, apply these tools to your own practice. Take the PHI for you and your staff, okay? Hand it out, have them take it and say, all right, what do we need to do to make sure that we're all optimizing our own health and self-care? Very often, skills like mindfulness practices, rechanging the mind space, allows you to listen to the patient and then see what emerges out of the visit after they've taken these questionnaires. And that can facilitate empathy, listening, and a deeper kind of conversation to get to know the patient and find out what matters. That enhances the quality of the relationships with your patients. And that in itself is a wellness enhancing, burnout mitigating factor. So, if it isn't just for your patients, do it for you.
All right, fantastic. Dr. Wayne Jonas from Healing Works Foundation has been our guest. Thank you so much for sharing with us your perspective on whole person care and for the important work you're doing to advance understanding and integration of this model. Thank you for listening. You can find links to the resources mentioned in our discussion in the episode description. Check out the Healing Works Foundation website at healingworksfoundation.org. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.